Hi guys, before this episode starts, I'd like to apologize because during the interview, the camera had a little bit of a glitch, and unfortunately, Dr. Cheryl got cut out of the picture when I tried to edit the video. So she was so cool about it though that after I told her that unfortunately the glitch happened while we were recording the interview, she said it's okay. You know what? We can post the interview like this, and then we'll do a follow up in the near future to talk a little bit more about it and hopefully get the full video. So thank you, Dr. Cheryl, for being so cool. And again, thank you guys for understanding. And I apologize for the glitch that the camera had. Right? Enjoy the episode. Hi guys, it's the Chappiness guy. Welcome to this episode of Vestibular Talks, episode number 18. Yeah. Um, if you're suffering from headaches, dizziness, anxiety, don't worry anymore. We have the DC Sortiers here to help you out. The DC Sortiers are two amazing, wonderful doctors from the Neurovisual Center of New York. Dr. Cheryl and Dr. Marissa are going to discuss a little bit about vestibular conditions and their relation with the visual aspect of it. So with our eyes, how our eyes are directly linked to it. Uh, in a brief introduction, Dr. Cheryl and Dr. Marissa have been especially trained to diagnose and treat patients with an often overlooked eye misalignment condition, which could be causing the headaches, the dizziness, the vertigo that we call, or the anxiety. So please tune into this episode. I hope you guys enjoy it, and if you like it, remember to give it a like, subscribe, and of course, share with your friends. All right, see you soon, guys. All right, doctors, we're live.
Hi.
How are you ladies doing today?
Good.
It is an absolute pleasure and an honor to have both of you in the Vestibular Talks show today. So thank you very much for taking the time to do this.
Thank you. Thank you for having us.
All right, yeah, it's my pleasure. So will you ladies be able to please introduce yourselves and give a brief introduction of what you do?
Sure. So my name is Dr. Cheryl Berger Israeloff. This is Dr. Marissa Zimmerman, and we are very specifically, we like to let you know we are neurovisual optometrists. What we do is we deal with the visual component of dizziness. That's our primary practice, is dealing with the visual components of the dizzy patient.
Mm-hmm. All right. So as I mentioned earlier while talking to you doctors, we are going to do this interview kind of like question and answer based to see if we can help as many people as possible, because I told a few patients that I was going to be interviewing you guys, and the response was extremely overwhelming. Like everybody started bombarding me with questions. They're like, oh, we want to know more about this and about that and about this. So I gathered a few questions which I emailed to you guys prior to this.
Yeah,
So let's try to get into them. So first question, from your website, which I've been checking out, you mentioned recently the number of patients diagnosed with vestibular migraines has increased. Vestibular migraine symptoms range from dizziness to lightheadedness and double vision. So my question to you is, what kind of testing would you recommend to diagnose a vestibular condition versus an eye condition?
Want to take that?
Yeah, so first, I mean, we have two great vestibular therapists that are close by to us, so it is nice that we're, able to refer to someone that we trust. The main big test I'd say would be a VNG or an ENG that would be able to test the patient's vestibular function. There are a few other, like the VEMP that some of them will also do too. Some just not like the Dix-Howpike too, to test for BPPV.
Yeah, we like to have as much information on the patient as possible. I think one of the big things when people get diagnosed with vestibular migraine, they had all these different tests done, and frankly, all the tests come out negative. And so they tell the person, you have vestibular migraine, because they don't find anything wrong with the patient.
Yes.
We find very, very often the problem can be it's either coming just from the visual system, or it's a combination, because very often someone who has a vestibular deficit is relying more heavily on their vision than the normal person. And so they have all those symptoms. My eyes are hurting, my neck is hurting, and it's these very subtle problems in the vestibular condition that the visual system that we can improve upon and move that patient forward. And also, frankly, my personal belief, just over the years, I think there's things that in the vestibular system that we just cannot measure yet. And just because we cannot measure it doesn't mean there's not something wrong. And I tell people that they might just be getting aberrant signals coming from the vestibular system into the visual system. The visual system and the vestibular are very much tied together. It's how our systems function. It's not just the ears alone. It's not just the eyes alone. It is not just your proprioception alone. It all works together, and it's controlled by the brain. So you have to look at that patient as the whole patient. And I think that's part of the problem, is people are only looking at one system and not how they interact together. And so when they can't figure out their little part of the system, they just say, well, we don't know what's wrong with you. You have vestibular migraine, or you have anxiety, and that's what's causing this. And then that person is like, you know, basically, one doctor said is people do what's called hot potato with them, meaning like, I don't know what's wrong, so this is your diagnosis. I'm going to throw you off on somebody else. I'm going to throw you off on somebody else. And we find a lot of people, especially, I see all the time in these chat rooms, I get double vision. I feel better when I close one eye. My doctor says it's vestibular migraines. If you feel better when you close one eye, it is visual. And that's one of the tests on our website. We tell people, we call it the 5-minute cover test. The instructions are on the website. If you feel better when you close one eye, we can help you. There is a huge visual component that wasn't addressed.
Absolutely, and it's very interesting because from your website, I actually done the test myself that you recommend in the video, and it's because I've been diagnosed with vestibular migraines, but even my wife and my son that are in perfect health, I told them to do the test as well, just to see if they have any sort of issues with their eyes. They don't really experience dizziness very often. My wife does every now and then because she works with computers almost all day long. So that's why I wanted her to try it. I wanted to say, hey, is this really related to migraines, or are you maybe having some sort of deficiency with your visual field in your eyes themselves? So when she tried the test, she's like, I kind of do feel a little bit better when I close one eye. And I said, you really need to see an eye doctor. Now, this is the best. This is the best part of it. Eye doctors, you guys are based in the States. I live in Canada. When I started experiencing these vestibular symptoms, I said to my doctor, I need a visual test. They sent me to the optometrist. He did a test and he said, no, your vision is almost 20/20. And then I said, no, I think there is something deeper to this. They then refer me to a neuro-optometrist to do deeper testing for my perception and all of that. When they found out that I have a convergence excess, I asked them, why aren't these tests more regular for everybody? And the answer from the neuro-optometrist was shocking. She said, it's because many doctors don't even believe that this is an important field of vision or medicine. They said, oh, if your vision field is 20/20, then you're good. Your eyes have no problem. When in reality, there are about other 19 fields that involve the eyes, correct? So what do you guys think about that?
I think I'm happy that you went to someone who was able to figure out what's going on in your visual system. And this is one of the things that we find very interesting about the visual system. Number one, I say it all day long to people, humans are visual. It's our primary sense. You learn from your vision. You take in information about the world from your vision. And it's not just, here's one eyeball, it sees clear. Here's another eyeball, it sees clear. Okay, the globe itself is healthy. How are the two eyes working together? How is then that information being transmitted into the brain, and how is that person perceiving it? So and that's the interesting thing about vision and vision science. And I think that's one of the things that does set us apart, is we really think about that. and the human visual system. I mean, we have brain pathways that tell us, when lines are butted up against each other, when it's so unbelievably complicated, and it is so important. When we detect, as opposed to a lot of other neuro-optometrists, that's why we separate ourselves as neurovisual optometrists, our treatment plan is a little bit different. So as for a lot of people, they do eye exercises and vision therapy. We use micro-aligning lenses to really measure very precisely the problem with the way the two eyes to work together. And we incorporate these lenses in a tool into your eyeglasses that basically give you a tool and solve the problem. So we get a lot faster relief, it tends to work out less costly for the patient too, because vision therapy can be very expensive and take a very long time. And then once you stop doing the exercises, it goes back to what it was. So, yeah,
it reverts. It's the original.
Right, I mean, it's hard to say how long,
but it can happen. So, and people need to get back to their lives. They need to get back to school. They need to get back to work. They need to function, and they want to feel good.
I mean, the other thing that's hard is, trying to train, like when I'm also a Convergence excess. I wear microprism in my glasses. It's very hard to train divergence. I mean, everything in our world, you're converging, you're sitting on a computer hours a day to try and work on, diverging your eyes, or if you have this vertical heterophoria, a vertical misalignment, you can't train one eye to come down and one eye, to come up.
Right.
It's just, that's not how the eyes work together.
We don't have conscious control over that. And that's really common, especially small misalignments coming from aberrant signals from the vestibular system. And you really can't train that.
Okay, will you doctors be able to explain, because I know what convergence excess and convergence deficiency are, because obviously I'm involved in it, but will you be able to explain to somebody that is just watching this episode that they don't know what it is?
Sure.
How would you explain convergence excess and deficiency to them?
Okay, so convergence excess, when you're looking at an object 20 feet away, our exam rooms are really long because we like to have as optically pure as possible. So I'm going to close the door, so maybe that's better. When your eyes are looking at something at a far distance, you want your eyes to be parallel, right? So, so some people, they don't diverge their eyes. They're not parallel. They're staying way too over-converged. And then when an object comes closer, you want to be pointing both eyes to the same point in space. So not only the images have to be clear at the same plane, both images have to be pointing to the same spot, so you don't see double. If you are convergence excess, you're going to over-converge your eyes. You're going to go past that point. If you're convergence insufficiency, your eyes, I'm convergence, I'm the opposite. My eyes go out this way. It's very, very, very hard for me to maintain that up close, that convergence. So I go the opposite direction. So if you over-converge your eyes, we call that posture ESO. You turn in esophoric. If you don't and your eyes go out this way, you're exophoric. Someone who doesn't have that is orthophoric. The vertical misalignment, vertical heterophoria or a vertical hyperphoria means one image is off on the up and down plane. And very, very often you have a combination of the two. So it's what's going on this way and what's going on this way, and be able to bring that together. Computers make things even harder because we were talking about the other day, a lot of the norms that we learn about in the textbooks as far as how good someone's convergence and how they do and how they're doing, they were tested doing it once, right? But we live in a world that you need to sit in front of a screen and maintain it for a really long time.
Hours, yes.
The human visual system did not evolve to do this. We did not evolve to do that. So very often we get patients that, again, were diagnosed with vestibular migraine or migraine, and that you ask them, when do they get dizzy? Well, I work in front of the computer all day. After that, and I'm scrolling on the screen. When I stand up and I look away and I try to do that, I'm like, ooh, I got so dizzy. That's ocular vision dysfunction.
Okay.
Yeah.
Before I move, thank you for clarifying that. Before I move to the next question, I gotta say, I love the alpaca in the background, the alpaca with the glasses. For a second there, I'm like, wait a minute, what is that? And then I was like, oh, it's an alpaca with glasses.
Yeah, I have like five different animals in here.
Yeah.
I love it. Going back to your website, when you mentioned that there is an increase on vestibular migraine diagnosis,
Yeah.
do you believe that is it because it's being overly diagnosed, as you explained at the beginning, or is it actually something, I don't know, in the environment or something, like, for example, using the computers too much, that is creating more and more patients vulnerable to vestibular migraines?
We
Overdone,
think it's overdiagnosed, and the computers are causing the problem from the visual standpoint. So the computers are causing a visual standpoint. Someone has all these weird symptoms.
But they're searching elsewhere.
They're searching elsewhere. They might have gone to get their eyes checked, but they got this,
Your 2020.
and the visual system, how it was working together, was never tested. So their eyes were healthy. They were, 2020, and they're told nothing's wrong with your eyes, and so then they go back to their ENT or an otologist or their primary care, and they're told, well, nothing's wrong with you, you have vestibular migraine. And that's what we see happening over and over, and it's just become this, what we call wastebasket diagnosis for people, that they're kind of thrown into it, and I do believe it exists, but I think it's way overdiagnosed now.
Something that is interesting, and we need to find a way to shift it. It's when I first saw a few eye doctors when this first was happening to me, and they said, "Oh, your vision is 20/20." I said, "What if I do vision therapy?" And they said, "No, that's only for people that had concussions in their brain. The vision therapy doesn't help with any eye misalignments or anything like that." How will you consider we can create more awareness to make this a more standard practice, that people actually believe that eye misalignment can affect your balance, the way how you perceive the world?
Yeah, I mean, we try doing things like this, and we try to put the news out there. We, have a YouTube video, and every time we see a patient, a new patient, we send follow-up letters. But it's really media attention, and I think that just the way our healthcare systems in both countries are set up, is people are very focused on their one body part, and that is one of the big problems. So I think just talking about it, creating awareness, saying to people, maybe you were misdiagnosed, you're not sure, just go online and take the questionnaire, and if you have questions, call us. Do the 5-minute cover test. It is so easy to do, costs nothing. Read the instructions, that's important. Take the 5-minute cover test. It's just a quick and easy way to say, you've got something going on visually. Yeah. It's simple as that. I mean, I've had patients that, I have this one guy, they told him that they were going to have to sever his vestibular nerve. It was the only thing, because he had hearing loss from a childhood. He said, no, I had that my whole life. That's not this. Do you know what his problem was? Because he went to someone who said, oh, one eye's 20/20, one eye's not so bad, it's like 20/30. It was uncorrected astigmatism in one eye. That's all I had to fix. Didn't fix anything else. He came back and he said, can you write me a note, because I want to go back to work. And it's just because someone thought 20/30 is okay, but it wasn't. His two eyes weren't working together on the same plane. Simple as that. He drove like 3 hours to see me. Didn't have to drive 3 hours to see me for me to fix that. That was easy. But these are the
imagine if thank God he found you, because if he wouldn't have, he probably would have gone through a medical surgical procedure that would have changed his whole life. Like it would have affected probably many other aspects of his life. So that's you did. So I am doing vision therapy, and yes, it is expensive.
Yes.
And I'm in my 24th session right now. Yeah, 24. This is week 24. They believe that after I finish my 26-week sessions, that I'm going to be better. Which maybe I will be. But with your treatment, your microprisms, do they have to last a certain amount of time, or people wear them for a lifetime, or how does that work?
Yeah.
Really depends, yeah,
Yeah.
on each situation. Like some of these concussion patients, I mean, I had a woman, she had the same care for 2 years, and then she came back because she wasn't feeling well anymore, and she actually didn't even need the microprism anymore.
Yeah, but for, you know,
people,
most like your traditional like dizzy person and like someone with convergence excess, like you or convergence, you were just born that way. So we incorporated into the glasses. We see someone once. Once they wear it, we'll see them back about 4 to 6 weeks later to see if the eye muscles has changed or relaxed. Once in a while, we have to see them a third time, but most of the time, after we see them the second time, we can get that person stable, and we see you once a year, and most of the time, once you have it in your glasses, you have it in your glasses, but it looks the same. And so very often, like I have a lot of people coming back now that we're coming from far away, and we have seen quite a few people from Canada and frankly all over the world. We get patients that saw us, they were doing really great, their glasses broke, they went to try to go to someone locally to reproduce it, and they just couldn't. Their symptoms all came back, and they couldn't. And 3 years later, they're coming back in, and they're like, "Doc, please fix me again because I need to work." Right. So that happens quite frequently because we're very.
Sorry, I was gonna say, is this microprism technology fairly new? Because I went to my vision therapist and I asked them about microprisms, and they said that they don't go as low as what you guys do. Like the correction, it can be that minimal. So is this kind of like a fairly new technology, fairly new treatment, or?
No, it's not that it's new technology. It's just that not a lot of people doing it. And our trial lenses, we can actually show you what we do. So this is a trial frame. So when someone comes to us, not only the power, we're very specific how we try that on you, but these are, this is a little quarter diopter prism. So we had all of these were custom made for us. So you can't just in your traditional trial set that you get a trial set, you wouldn't have these. We have all of these little trials, and they're all custom made for us.
Yeah, there's one lab in the country that specifically makes these lenses for us.
We use one lab that we
because most people, when they think of prisms, they think of these like
very
really long.
Yes, those are the ones that I've seen. Yes.
This is like the second box for us for double vision patients. We have all of our micros. They're all custom made for us, and they're custom made in quarter diopter steps. And right now we use one lab. It's a family-owned lab out in the West Coast of the United States who makes our lenses, because there's something called tolerance. So when you prescribe something, legally, it's allowed to be off a little bit.
And prism by usually a quarter.
And prism by a quarter. But in our patients, little bits matter. So that's what I tell people all the time. Little bits can make a world of difference. So our lab knows that it's got to be perfect, and it doesn't pass inspection if it's not perfectly correct. So it's really just being very precise. But you have to have the toolbox. So if you don't use that toolbox and you don't have that toolbox that we have, you're not going to be able to measure these things. We have the toolbox.
And we trial frame it at the end so the patient knows what they're going to be getting in their glasses when they pick them up after they're made. So they know if it makes a difference or not. We rate their symptoms before we do the whole exam, and then afterwards when we trial frame the final prescription, they then, rate them. And I'd say most of the time, most people have at least like 40 to 60%
right away
reduction right away
after wearing it.
Really? Wow, that is huge.
It's huge. We have people walking around. I've even had patients, we get a lot of people that are only dizzy while they're driving. And I'm known to take tape and tape things. If they're regular glasses, the power's good. I'm known to even tape things and have them go and drive around to see if it helps to test things out. Because we get a lot of people,
a lot of
divergence, insufficiency. People get a lot of dizziness when they're driving because when they move their head, they split a little bit.
Yes. So now let's say that somebody actually does have vestibular migraines and their vision is a little bit off due to the migraine itself. Will the microprisms still help alleviate some of those symptoms or no?
It can, yes, if we find a binocular vision problem. So very often, say someone has something wrong with the vestibular system, you're going to rely more heavily on your vision so you don't fall over. So that's why someone will say, they got an episode of a virus, vestibular neuritis or BPPV, right? And now all of a sudden they're diagnosed with vestibular migraine after that. Well, what I really think happened is something happened to the vestibular system, and there is damage there. And once you have damage there, a lot of times there's no easy, quick fix for it. And you're going to rely more heavily on your vision.
Right.
It's our primary sense. And so then you get people, why do my eyes hurt so much? Why am I so light sensitive? Why does my neck hurt so much? And I tell them, well, your neck hurts because you're using those muscles to keep your head up, right? So a human will do anything to stay upright. So all of this is all contracted and hurting. So very often when we just fix the visual system for them perfectly, they get a reduction in their symptoms. We can't cure if someone has a real damage to the vestibular system, but we can make this as perfect as possible to help people move forward and function better.
Really,
yeah.
All right. The following question: roughly what percentage of the population could be suffering from an undiagnosed eye condition, such as binocular dysfunction or convergence problems, that could affect their vestibular system?
Oh, I think it's at least 20% of the population.
That's a big number.
We think it's at least, we used to think it was lower, but the doctor that trained me, when she would talk to huge conferences, like she'd go into a room with, a few thousand people, they'd hand out questionnaires just to see how people scored, because it's quantified. So we kind of can tell from how people answer those questions. And they used to think it was like 10%, but then they get sometimes they're like at least 25% of people. And if people just start noticing how many of your friends, when they're looking at their phone, they go like this and they close one eye. You'll be like, oh man, that's a lot of people who do that. It's extremely common. It's extremely.
All right.
Yeah.
What about, does exposure to blue light, such as computers, phones, or TV, increase the chance of developing these visual or eye misalignments?
I'm going to say no. I don't think that blue light increases the chance. There are there's a few things that we know what blue light does, and we're a little bit about like the cataracts maybe and ocular health, and the jury's a little still out on that. We know it definitely suppresses your naturally produced melatonin, so you don't sleep as well. Therefore, you're more tired, so you get more symptoms when you're more tired anyway. Also, blue wavelengths tend to scatter more and flicker more. So when someone is exposed to that, and their brain and their system is so sensitive to what we call the flicker, meaning because it gives you a sense of motion, like fluorescent lighting, the blue wavelength. So we find different filters can just help calm that system down. But I don't think, it's not going to make you have a binocular vision or vestibular problem if you didn't have that already.
Okay, could you develop?
It might make you more symptomatic, but it didn't cause your underlying problem.
Okay, having an eye dysfunction or a visual dysfunction, could that affect light sensitivity? Like, could you become more light sensitive to?
It always does. Yeah, it almost always does. Yes, okay. You might be more sensitive to the light, but the light didn't cause the problem. It's kind of the opposite way around. The problem caused your sensitivity to the light.
Okay. How about, does aging increase the risk of developing these eye conditions?
100%. So what we tell people is there are 6 little muscles that are attached to each eyeball. So they have different functions. One of their functions is to keep the images superimposed. The other is sending signals into the vestibular system back and forth, that when you move your head, you're moving your head and the world's not moving. But these little muscles are like the same as our bicep muscles. And as you get older, the muscles get tired, they fatigue. And when they fatigue, you get all these complications. Yep, exactly. So 100%.
So how long, well, we kind of already talked about this a little bit, but how long does the treatment last if you're using the microprisms in order to see any correction? But you mentioned that some people see changes basically right away.
Yeah. We on average will get around an 80% reduction in symptoms after we get the prescription finalized, and that's kind of
no other underlying.
If they have no other, right, exactly. Like we tell them we can only fix the visual component, but say there's no other underlying, bad vestibular will get about an 80% reduction in symptoms. And I have patients that, 5 years down the road, they're still doing great. Yeah. They're doing great. Years and years.
Good. How about what steps should people take to help avoid these visual conditions?
Well, I don't think you can avoid it. A lot of times you're born with it.
Okay.
The only thing that we know can precipitate it starting is head injury. Yeah. So we always like to avoid head injuries if we can.
Trauma,
that's a huge thing, trauma. So so the only thing that can precipitate that happening if you weren't predisposed and just kind of born that way is trauma. So there's nothing you can do other than try not to get in accidents to stop anything from happening. But of course, listen,
Lyme disease
and other neurological problems can also precipitate it. Lyme disease, mono, Epstein-Barr, anything.
Even in case of the flu, and then afterwards they just can't
decompensate. But they were prone to having the problem anyway. So just that stress on their body made them decompensate. Right. So there's very little that anybody could do to stop it. You would say, oh, don't use a computer as much, except we live in 2020. So I think we're realists. Yeah. We're realists. And, it's like, parents come to us and they say, well, how do I stop them from using their phone in that? I'm like, well, I don't know, because I can't stop my kids. Right? So I don't know. It's just the world that we live in. It's just the world we live in. Yeah.
It's interesting that you mentioned Lyme disease and the Epstein-Barr virus, because are you familiar with the Medical Medium books and Medical Medium podcasts? So they talk about how the Epstein-Barr and maybe even Lyme disease can be connected to so many conditions that have been misdiagnosed for years.
Oh, yes.
And many doctors right now still dismiss those things. I could go to a doctor here in Canada and say, hey, what if my symptoms are related to Lyme disease? Yeah. They're like, no, that's not real. They're like, Lyme disease is just a rash. They said it's just a rash, but it's not. So thank you for touching on that topic, because it shows me right there that you guys are both very educated and aware of that not only one thing can, like, for example, not only your visual and vestibular are directly connected, but many things like the Epstein virus or Lyme disease or something else could be affecting those systems as a whole. So
those are the people that are the hardest to stabilize over time. And that's why it makes you think, oh, something else is going on
here. Something else, because they have other things that are affecting them neurologically, their brain pathways. And as far as vision, I mean, over 60% of our brain pathways are related to vision. That's how important it is. And so if you have a infectious disease that affected those pathways neurologically, it's how your brain functions. So you have this functional problem caused by this microorganism that just made those neurons just not work the same way. And it's very real. It's 100% real. We've even seen people with problems getting things from mold toxicity and things that just for something like, it affected them neurologically. And just because it's not seen on an MRI, there are things that we see now on scans that, frankly, 10 years ago they didn't see because they didn't have that technology. So if anybody tells you that they know everything about what's going on in a human brain, that means they know nothing, because there's so much we don't know. Things happen on the cellular level that we cannot measure.
Yeah, well, and I was listening to a podcast the other day that says that our eyes, everything that we see, it's when our brains interpret that information is about only 10% of the actual reality of that we're seeing. Like that, our eyes actually have the capacity to see much more and many more colors and many more things, but our brains are only seeing about 10%. And I imagine that in a few years from now, technology is going to help us even increase that to 20, 30%. So you're right. Just because someone doesn't know anything right now doesn't mean that in the future it's not gonna be more well known or it's gonna be more connected to that.
Correct.
So So somebody asked me, are there any surgical procedures to help correct the misalignment of the eyes rather than using the prisms?
It really depends on the amount. I mean, for us, the measuring of the micro I mean, no way would I ever recommend anyone doing surgery. It's more the people that come in, and I mean, even someone on the street would look at them and they see an obvious, I mean, an extreme like strabismus, an eye turning out, an eye turning, in towards the nose where you see, barely the colored part of the eye because it's in so much, or the eye's completely up. I mean, those are more, obviously cosmetic. But even, if the patient's not suppressing the eye too, and they're seeing double images so far away, there's only so much that we can grind into lenses.
Optically,
so there's a maximum for how much prism we can get in there.
Right. So
but most people know. I wouldn't recommend surgery.
For micro, if your misalignment is that small, you can't, because the surgery is not that precise. You can't say move something a half a prism diopter. Prism diopters just measure a distance. We're just moving things. You can't do that surgically.
They're measuring like 12, like 16 diopters.
We only send people for surgery for double vision patients that optically the images are so far away, we can't get it together. And often those patients, once they're surgically corrected, say the image is this far away, 12 prism diopters, they still need a little bit prism to get it perfectly together, or else they can still be symptomatic after surgery.
All right. Are there any medications or supplements that could help you treat the symptoms that come with eye misalignment?
Okay, so to help you with the symptoms, some medications actually make your misalignment problem and your fusion worse. The benzodiazepams we hate those. They're worse.
Really?
Yep. Not a big Topamax fan because I feel like cognitively it really messes people up and you get this brain foggy feeling. We're big fans of D2, magnesium, and CoQ10. Those three together, you have to give it 8 to 12 weeks really to kick in. But if you're really having migraine, and that's where it's coming from, those three supplements can really help suppress those symptoms. We always recommend people drink enough water. Exercise. We're huge into exercise.
And diet too, how important. I mean, people say,
diet is key. Diet
and exercise. And again, a lot of times people are diagnosed with vestibular migraines and then they're told to eat really healthy and eat a low salt diet. And when I think about that, these little organs in the inner ear, there's fluid that goes around them, endolymph, and it goes around them. And part of me says, well, if someone's eating this low salt diet and they're eating very healthy, it's affecting those fluid levels in the inner ear. And that's probably why they feel better. Barometric pressure affects the fluid level. So I think there's an actual physics that are going on that nobody really thought of. And it's not just a migraine, it's the physics of it and how these organs work and how complicated it is. So we're very into taking those supplements and diet and exercise, and also noise cancellation. So we know that when you move your eyes, your eardrums vibrate. We know that if you do nothing else and you put somebody on a balance board and they close their eyes, so we take away visual cues and you measure their sway. If you put noise cancellation headphones in, and you do re-measure that person has less sway. So their balance gets better. And we're taking away all their vision. So noise cancellation can help people a lot. And we recommend the Bose noise canceling earbuds, the QV20s and 30s. Those are the ones that we've studied, and they can work and really help people a lot.
Interesting. Thank you. Thank you for saying that. So I don't know how it is in the States, but here in Canada, when somebody's diagnosed with vestibular migraines, the first line of defense is amitriptyline or nortriptyline, which are antidepressants.
Yes.
If that doesn't work, then they do Topamax or propanolol.
Yes.
And if that doesn't work, they do calcium channel blockers like flunarizine, which is what I'm taking right now. Flunarizine.
Yes.
So they often revert to those medications to like they keep looping them. Oh, this one didn't work. Try the other one. That one didn't work.
It's trial.
But you're saying that it could eventually affect more, like the symptoms, like the visual symptoms more. In my opinion, it affects it more because they are they suppress the vestibular system.
Right.
So they kind of like make it dormant a little bit, and then when the system wakes up again, it's overwhelmed. It's extremely overwhelmed.
Yes.
But do they affect your eyes directly as well, or no?
know if we know the answer to that 100%. We do know that certain medications, and I actually keep a list in my office about what things are happening, but there are side effects of some of these medications that actually decrease the VOR gain. So the VOR is the vestibular ocular reflex. That's that signals coming back and forth. And some of these medications decrease that gain. And when you're trying to get someone's system like working together again, and you're on that, it can be a hindrance.
Yeah, Klonopin
is, and people weaning off that, just the side effects from that can be really debilitating for people. And that can be a real challenge, especially when we're working with one of our vestibular therapists and we're like getting this perfect and we're trying, and then we can't get their fusion stable because of the meds. And that does happen. Yeah.
Klonopin and Effexor are two big popular ones here too. Klonopin and Effexor.
Here too. It's the same thing. Here too. You know, and that's the way. It's like, okay, let's throw a pill at that person. Let's throw a pill at that person. Because, you know, to do the actual work to get that person moving forward, that it's sometimes it's hard work. We tell people, like, you know, we're going to fix this for you, and then we need you to go out there. We need you to walk and move, and we need you to do things like play a sport like that, because we want to gel those signals back and forth that weren't working. And if you kind of look at these stories on these either vestibular migraine forums or just vestibular disorder forums, the people who say, I am so much better, if you really delve into it, that's the person who said, that's active, and I made myself go and walk every day, and even if I felt dizzy, I made myself and I pushed through it.
Yes,
those 100%. Are the people that get better. Those
get better, yes.
That get better. I will always tell people, we're going to do this for you, but there's stuff you have to do, right? And
yes.
Huge believer in the diet and exercise, and, you know, good things in, you get good things out, and your brain just works better.
Sports like tennis and ping pong, I heard they're great because your eyes keep tracking the ball.
Very good, very good.
Yeah.
Something that I experienced, I don't know if you guys experienced it, when you're driving your car and you come into a parking space, you park, and the car next to you moves, and your peripheral vision sees a move, you feel like you're moving at the same time, even though you're parked.
Exactly. So that we tell people, and we actually talked to someone about that today. So that is a normal mismatch. That happens to everybody, but with people who are very sensitized to dizziness, their brain like goes into panic mode because they're like, oh my God, so it's something weird. Something that, you know, like when people are driving, we have people who, we get them really good driving, and then I had this one patient, she's like, I'm great until I go over 70 miles an hour. Well, there is more motion on the side, and if you're attending to that, there is more motion, and that's the laws of physics. So I can't change that. I can't change the laws of physics. It's your brain is so sensitized to something that all of us see and feel, except my brain blows it off, her brain blows it off and says, you know, I could get dehydrated and get a whoosh of dizziness, right? But I'll just be like, oh, didn't drink enough water. Someone with a vestibular problem or who's just very sensitized to it, their brain doesn't blow it off. And then they secrete stress hormones, and the stress hormones make things shake more. So it becomes this vicious cycle. And I think also we discussed this with the gentleman this morning. Part of our job is kind of to tell you what everybody feels and what everybody doesn't, because it helps you then go, oh, okay, I am okay. I don't have something like a brain tumor, because that's where your mind goes. Oh my God, you see that? And that's a normal mismatch. That's physics. And it's not, you know, it's not a migraine doing that. No, that's real.
Many more people that I'm seeing, younger and younger people, keep getting diagnosed with vestibular migraines and Meniere's, which Meniere's disease is something that you don't really see in young people.
Correct.
And their main symptom for both vestibular migraines and Meniere's is usually what they call visual vertigo. Correct. So I am almost 100% sure that if they will fix the visual vertigo by coming to see you guys or another neurooptometrist that knows about this, their condition will resolve or go away. So, but instead, they are giving the diagnosis of like, no, you're 20 years old, but you have Meniere's, and it's for the rest of your life. So they start injecting them in the ear with different things.
Oh, yeah.
So do you believe that in order to properly get up a real diagnosis, whether it is Meniere's or vestibular migraines, some of the first steps that a patient should do would be seeing you guys, like seeing you to determine if it's in their eyes?
You know, again, it's so easy to tell if you have a visual component. If you're suffering from visual vertigo, you walk in that, cover one eye. Does it go away? Yeah. It doesn't. Do you feel better? If you feel better when you cover one eye, coming from binocular vision dysfunction.
And even the Meniere's,
very simple.
Misdiagnosed, and the person doesn't even have hearing loss.
Oh yeah, we
exactly.
Did even do any hearing? Oh no, they didn't do that test. They just said based on what I was saying that I have Meniere's.
Right.
But it doesn't work that way.
Right, it doesn't work that way. Another one of our favorite things is when a patient comes to us and they say, well, I was diagnosed with vertigo.
Oh, yes.
I'm like, well,
that's a symptom.
That's a symptom. What does that mean? That's not a diagnosis. It doesn't tell me anything.
And then even ENTs that give them that.
Yeah, that give them
even written on a paper. I'm like,
because they're not, you know, the dizzy patient is frustrating to a lot of doctors. The person's a little puzzle and it takes a lot of time. You really have to listen to the person. And when you have 10 minutes with somebody, you can't. So that's what happens to people. You know, we take 2 hours, at least 2 to 3 hours. But when we first meet somebody, I mean, when I hear the first thing I say to someone after we do some what I call normal eye exam things to make sure we're not dealing with an unhealthy eyeball. And when I say to people, tell me your story, everybody says, oh, it's a really long story. I said, that's okay. Everybody's story is really long. Because I think it's instructive to know. And when people remember when it started and that day, like, what were you doing? I think it's very instructive for us. Yeah.
All right. Let's get to some more in-depth questions about your actual practice. You're located in New York. How difficult is it to get an appointment for someone located outside of New York or outside United States?
It's not difficult at all. And we try to accommodate people traveling to us with certain dates and times. You know, I've been known to move around to other people if someone, you know, is getting a flight or knows they're traveling. You know, we're not that far from New York City, so a lot of people come because they're coming to see New York. And
a train that comes to us.
There's a train, they Uber right over. We see a lot of people from all over the world. And so it's not that difficult. You know, there are 2 of us here now, so we can get people in fairly quickly within, you know, a couple of weeks.
All right.
Yeah.
What is the average cost for testing, diagnosis, and treatment?
So people in the States, we do take a bunch of medical insurance, but it varies. Outside the state, our initial evaluation, which takes us 2 to 3 hours, is $500. And then depending on if we find something we treat you, it really depends on how much the lenses cost, depending on how old you know, the frame, or people bring us frames. So that's an aesthetic and it has to fit properly. But it also depends on the age of the person and what type of lens we have to use. We hear people saying, right, those Prism lenses were so expensive. The actual Prism, putting it in, is quite inexpensive. It's when we need to use a progressive lens to really get that vision on the same plane everywhere. If you need a full progressive lens, it's the quality of that lens that we use, the optics, that is expensive. So just that base lens can be over $300, that lens. The actual Prism isn't what's expensive at all. So it really depends on each person individually and how we have to fix that visual system. And a lot of it is just their underlying symptoms. Another thing just to throw out there that I think people need to know, dizzy patients. Oh, I was told not to use a progressive lens because it's not good for a dizzy patient. Well, I'm telling you, dizzy people need their vision, and we live in a very intermediate world. Right now I'm wearing a progressive. I can see you clearly because I have my intermediate in here. And if you are wearing single vision and everything here and you're switching back and forth and it's totally blurred and your system is spasming, you're going to get worse. So there are certain conditions that we do deal with that we tell somebody, your eye just doesn't go down, you cannot use a progressive. Physically, it's very, very interesting to me because we have the patients that we know physically they can't use a progressive because they have a damage to a muscle, a actual physical damage from an injury. They're the people who only want it, and we're like, I don't know, I don't think that's going to work. Your eye just can't get into it. And the people who are just dizzy, who we know that's part of the solution for them, they won't even try to adapt to it. So that's another hurdle that we deal with a lot of people,
and especially the dizzy when driving people. Those people, I mean, 99% of the time they need a progressive.
They need a progressive.
You know, the reason a lot
that's
of
the reason. Yeah, that the symptoms are happening. So it's not contraindicated at all. In fact, it's
Unless,
good.
I mean, yes, we do have patients that come in there, you know, in a wheelchair, you know, where they're looking out of the lens. But I mean, I'd say at least what 80-90%. I mean, we definitely recommend.
Or in some kind of multifocal lens. Yeah, with some kind of reading boost.
All right. Something that you guys wanted to talk about was third window defects, undiagnosed, misdiagnosed inner ear disorders that can be mistaken as vestibular migraines. We talked a little bit about it, but is there anything else that you guys want to push to that?
Yeah, I mean, I guess the big thing for us too is, you know, we do show a lot of the patients the Bose noise canceling headphones, and I'd say mostly all the time, the patients that don't like it are the patients that most likely like have a fistula, where we suspect, we suspect something's undiagnosed. Like a semicircular canal dehiscence. You know, they complain of this fluid leaking from their ears, this fullness, and you know, they said, oh, terrible sound sensitivity, but they put those earbuds in and they're like, oh no,
that's
get
terrible.
Those out.
We know, we start thinking that there's something that was misdiagnosed in that inner
ear.
Yeah.
And she even said the same thing. She's like, I knew it. She's like, I even, you know, she was a Googler, Googled the stuff. She's like, I knew I had, she's like, I really think it's, you know, a fistula.
And we picked up a couple of those kind of people, and we send them to specific doctors here to
usually a neurologist
that really look. Superior canal dehiscence is rare, but when your whole practice is dizzy people, guess what?
You'll see.
You get to know a thing or two,
Exactly.
I mean, you know, when you ask patients the question, you say, oh, do you hear your eyes blinking, or you hear your heart rate? And when they're giving you weird looks, I'm like, all right, most likely that's not you then.
But when you had somebody like, you know, wow, I did notice that once in a while. I'm like, when you move your eyes, do you hear it? Do you hear a scraping sound? And they're like, yeah. I'm like, uh-huh.
Changes in their pressure.
I'm gonna say this in very rough, vulgar terms, but I'm very happy that you guys know your shit, because you know your shit. Like you both are very well educated about this. You not only about the eyes themselves, but how the eyes involve the vestibular system, your balance, your neck, and the pain that people usually feel, because people say, no, I don't think it's my eyes or my ears, I think it's the neck because I feel pressure in here. But you're right, like the vagus nerve controls the movement of the eyes, so it can also affect this area. So I'm very glad that you guys are very, very well informed and educated into the whole holistic approach of healing.
Yes.
So yeah, thank you.
That's
great.
How things work.
How about how to treat symptoms of dizziness?
Well, I think the first thing, like I said, when we have someone, depends. I think the first thing, you have to listen to that patient, and you have to find out what makes them dizzy. You want to know what they feel, because you can say and describe your dizziness, and you could be talking to somebody else, and they can have a different sensation of dizziness, and they're both called dizziness. So a lot of these symptoms and different conditions, not only have a lot of comorbid conditions, but they overlap. So dizziness can be caused by a lot of things. So the first thing is
blood pressure.
I had a woman that was sent to me, and she's like, I forgot who she was sent to me by, but she's like, I'm dizzy, and I think, and I'm thinking, something made me think about.
I think she said too, after I eat, I get dizzy.
And then I had someone, well, when I move like this, or when I get up, and there was just something triggered in me that says, let me test this woman's blood pressure. And her blood pressure was crazy. Guess what? You know, if your heart's not pumping enough blood up to your brain, you're going to get that lightheaded dizziness. So you have to listen to the person. I think that is the history. We spend a lot of time listening. And that's the first step, is listening to the person. Because I tell each person, you're a little puzzle, and we've got to figure out where this is coming from and what's treatable. If you really truly have a real problem in that vestibular system, other than a fistula or another third window defect like SSCD, if you have some damage to that system, there is no magic pill that is going to cure you. So you cannot just take a pill and say, my vestibular nerve is working again.
Right. 50% to 100%.
There's just no magic for that. Our only treatment for you is to stabilize your vision as much as possible and then move your body. The therapies and, like we said, those racket sports and that, it's the best thing. So a lot of that is and getting that person to understand that. You know, we want in this 2020, people want a magic. They want it to just, okay, cure me. That's why we have this, you know, epidemics of diabetics who you say you can control this with diet and exercise. Oh no, they want a pill. You know,
magic pill. Yeah.
And the magic pill. And frankly, a lot of these things, there's no magic pill. So I think that's always our first step is
expectations too of some of these
the
patients
history
that have a lot of
comorbidities. So you have to. The history is, I think, the first thing. It's really important. Yeah.
We're almost done here, guys. One of the last questions is, we already discussed it a little bit, but how do you differ from vision therapists?
Okay, so we don't, it's our treatment plan, and also we are very also focused on finding very small vertical misalignments that are usually totally blown through in someone doing, right. So we don't just go by our numbers from our phoropter, which is the little thing they put in front of your eyes, which is better 1 or 2. This is our favorite tool. And this is a very fine Maddox rod. And what the Maddox rod shows us is it gives us an image from one eye that separates from the other eye, and we can precisely measure where those images are in different places, different areas of gaze, and different distances, because it can change. So what we do is we measure that precisely, we figure out what's happening, and then we correct it with our little micro. So if you have one image that's slightly higher than the other, we bring it together and we figure out which is the best way. We look for different patterns when you move your eyes, and we do that. We don't give you exercises. Very rarely do we give you any exercises to make things better.
The people that are convergence insufficiency, and it's real. I mean, sometimes it's cosmetic. Someone has like an intermittent turn just to keep their eyes
together, and really like once in a sometimes we'll give people some converging exercises. We always do it home based because 100% we believe it's what you do on an everyday thing. It's not, it's like going to a trainer once a week at a gym and doing nothing the rest of the week. Nothing's going to happen. So, and it's really, we only have conscious control over that convergence, being able to do that. So if you have any other problem, half the time people never develop learning how to converge because they have one image up here and one image down there. So how do you ever learn to get it together? So frankly, that's it. I mean, I'm a terrible convergence insufficiency. I did vision therapy twice in my life, extensively. You know, I'm 54, just not doing it anymore. So I have a separate pair of glasses when I'm really doing heavy computer work with extra horizontal prism to help keep my images together. It works like a charm, and I got no problems. So
there you go.
We have a different treatment plan. So we get quicker results for.
I mean, they come for their 6-week evaluation, and again, even if you come from out of state, out of country. We had someone where they're from Italy. Luckily their power in their glasses was correct, so we gave them the prism, taped it on. They went off into the city. They had it for like 2-3 days. They came back. We remeasured it just because they weren't going to fly back in 6 weeks. We were able to make adjustments, and then we mailed them their glasses in about 2 weeks.
Yeah.
So usually, I'd say some people do need an adjustment at that second visit. Yes. But in some of these extreme cases, just a little bit that we find then makes a huge
difference. Huge difference. Yep. Mm-hmm. Yep.
All right. Where can people find you if they are trying to get a hold of your website, your social media? How can they get in touch with you?
So all you have to do is Google the Neurovisual Center of New York. Our website is nvcofny.com. And you can find links. You have a little link and it says take the test, and that's the questionnaire.
It gets emailed to us, so we'll email you or either call you depending on where you're located.
Depends, out of the country or farther away, because sometimes we can get a lot of questionnaires. We'll send you an email back with your score.
Yeah, and 5-minute test if you didn't do
and our phone number if and a link to the 5-minute cover test. And our phone number to get more information. We're 516-224-4888. But if you go to our website, it's take that questionnaire and do the 5-minute cover test.
All right. Well, it's been an absolute pleasure talking to the both of you. You're both very knowledgeable, very informative, and I can tell also that you're both very compassionate. So that's great. Like, that's a great quality to have, especially being in the medical field, because many patients that deal with dizziness, they are so frustrated and overwhelmed that finding a doctor that actually listens to them and takes the time to acknowledge their story and their symptoms makes a world of difference. So thank you very much, guys. I really appreciate it. I am obsessed with that alpaca with the glasses in the background. I want to see where I can buy one of those for my own place. So yeah, no, thank you very much. And I hope we can make a big difference with this video. We're gonna definitely, I'm going to share it with as many people as possible. And yeah, and I hope we can do a follow-up in a few weeks or months even. And don't be surprised if I come to visit you guys in New York, because because you gave me a lot of hope that that my dizziness can be, if not resolved, at least relieved by working on my eyes. So thank you very much, guys. I really appreciate it. Have a wonderful day.
Pleasure. Have a great rest of your day.
Thanks.
Take care. Bye.
Bye, guys.